Good afternoon, everyone, and thank you for joining us for another web conference being hosted by the Agency for Healthcare Research and Quality Health IT program. This afternoon, we have two excellent speakers lined up to speak about using Health IT to support improvements in clinical workflow. Before we begin with presentations, I have a couple of housekeeping items. We will begin with welcome and introductions and then move on to presentations. As Sean noted, we'll then conclude with the Q&A session at the end of both presentations, and we have a slide with instructions on obtaining CME credits. Before we move to our first presenter, I wanted to let you all know that neither the presenters or myself have any financial interest to disclose. Sean has already covered how to submit questions using the Q&A feature on WebEx. Here's a screenshot for those of you who may not be familiarized with the WebEx interface. In case you need to see, please submit questions and answers to all panelists, as Sean indicated. And before we get started, I just wanted to give you a bit of background. Both of these projects were funded under a funding opportunity announcement that was focused on understanding clinical information needs to help us understand how to best support clinical work using Health IT. So our first presenter this afternoon is Dr. Keith Butler, who is a principal research scientist at the University of Washington in the Department of Human-Centered Design and Engineering. He is one of the originators of the field of usability engineering, lead author of the ISO standard for usability testing that was recently adopted for AHRQ certification, and a member of NASA's Standing Research Review Panel on Space Human Factors. Before joining the University of Washington, he was a technical fellow in Boeing Math and Computing Technology and director of future products and architecture in Microsoft Global Services Automation. Without further ado, Dr. Butler.
I'd like to begin by thanking our full team. Access to clinicians is a key for user-centered design. And so the MS Clinic at Puget Sound VA, the Center for Pain Relief at the University of Washington, and the Emergency Department at Baylor Scott & White are key partners in providing us with expertise. I'd like to give this talk in 4 parts. Briefly talk about the need for benefits of Health IT that are predictable as well as beneficial. Then there's a new standard for business process modeling that we've adopted for workflow I want to describe. Then there are some common disruption patterns of Health IT that we've observed, and then we'd like to show you some examples of not only how to identify them with workflow, but also to generate the design ideas to fix them. I think it's intuitively obvious that the risk of unpredictable impact of Health IT is a serious problem. Health IT has a big impact on workflow. An information system is really a tool to get information and change it. And like all tools, it constrains the way you can do your work with it. Just as the design of a wrench constrains the way you have to move your hands to use it, to adjust a bolt, an information system constrains cognitive work in powerful ways. And until recently, we didn't have a way to make that explicit. So our challenge here is, how can we represent the work of clinical care to analyze how it should be improved with Health IT? And that involves understanding the current situation and how we're going to make a transition to a better situation through the appropriate design of Health IT. People have been modeling work for a long time, even since the Industrial Revolution, so there are a lot of ways to do it. The way that we've decided to focus on is a recent standard called the Business Process Modeling Notation. It's a standard of the Object Modeling Group. And most of you are probably familiar with that as the OMG. It's about the most influential software standards body in the U.S. and probably the world. People have been using data flow diagrams for a long time to model workflow, but there's really no way to account for the fact that in the physical world, you need resources for activity. And especially in clinical care, the use of information in the physical world can generate changes to that information. And so in order to account for the entire information flow, you need to understand how information is used and changed in physical activities, and not just with a clinician sitting down and using a computer. And so that complexity is one of the purposes of this recent standard. To understand IT requirements for people doing work as groups, and it's in the support role that computing is. It's not the end of itself. There's a good tutorial that's available, but we'll also be going into some more detail here. Before I move into that, though, I just want to remind us that all models are wrong, and some models are useful. So we're looking for the sweet spot where we get the right amount of detail that reveals what is the current situation with clinical care with respect to its workflow, and how can health IT improve that workflow. Here are the basics of the BPMN standard. On the left-hand side, you see that some instance arrives, and that's also called a token sometimes. It could be a patient that arrives at a clinic. It could be a test specimen that arrives at a lab. And the activities that are performed on that instance need resources. They need information resources. They need physical resources. And what this illustrates is that the use of resources is an important dimension when you consider whether you're making a workflow better or not. It also illustrates that information resources can either come from computer sources or physical resources, including people. Documents, equipment, other clinicians, all of those are important places where information is used and changed in a clinical environment. Now, the little diamond that you see there indicates a contingency. If the work's not finished, then you have to do more. If it is finished, you go ahead. One of the most important things I want to point out here is that by making all of this explicit, several good things can happen. One is that information, when it's treated as a resource, really simplifies the workflow. Instead of it being a task, it's a resource, and you can separate that out. The other one is that when that instance arrives, its nature really has profound implications for the activities and the resources that are needed. Just imagine, if you would, the difference between an instance that's arrived where it's a pair of old shoes that needs to be resold, and compare that to the activities and resources that would be needed if it was a patient arriving in an ED with a high fever and nausea and reported that he'd recently been in West Africa. It's the job of the workflow to transform the state of that arriving instance into something that is its goal state. And that provides very useful guidance when you're actually building workflows. We can also make problem areas explicit. So if there is an information system that's going to be used, and there's some activity that needs that information system, very often we've observed that the user, clinician, has to stop what they're doing, do something to remedy the information resource, change its organization, transform the format, maybe it's in the wrong place at the right time, or vice versa. Whenever the user has to stop what they're doing and pay attention to the information resource instead of the real work. That's a form of overhead. And computer overhead is more than just extra work in clinical care. It can disrupt cognition, and at its worst, it can even disguise the true nature of care tasks. Here's some common patterns of that kind of disruption. You can probably generate the favorite one that you hate as well, but these are the ones that we've actually observed. They're not exclusive and exhaustive. They're rather things that we've actually seen with compensation patterns taking place. For example, the second one down on the left-hand side, information is in a single source, but it doesn't match the workflow. And so we've seen people transcribing information onto pieces of paper instead of trying to hold it in their memory while they go on to the next place in the information system, and then they're going to put it together. And so we see these patterns happening fairly often, and you see a lot of compensation going on. Now, here's some examples that are expressed as workflows of those kinds of problems. These examples are taken from an MS clinic that sees over 300 advanced patients every 3 months. And these patients are pretty sick. The doctor, we observed issuing as many as 10 orders coming out of most exams. More often there might be 4 to 5. And for these orders, there's at least 11 distinct types of orders, and each of them will have their own workflow. So in response to that situation, they've assigned a case manager, a senior nurse, nurse coordinator, who's responsible to monitor and manage all the treatment plans, to review the plan status, make appointment calls, confirm the patient's going to come in, and just generally serve as the primary focal point for any new problems for all 300 of these patients. Now, here's a workflow. Check that. Here are the variety of information resources that this nurse currently deals with. And we observed that there were at least 5. There's probably 6. And the EHR has most of the data that she needs to do this job. But it's distributed in so many different places that it's just not practical for her to check all 300 patients in all of these places on a frequent enough basis. And so over the years, they've invented these different information resources. Some of them are spreadsheets. Some of them are pieces of paper. Some of them are printed copies that are extracts out of the EHR. They're overlapping information resources. And as I said, no single one of them gives all the views that are needed for case management. So she spends time doing overhead tasks, trying to keep them consistent, sorting through them, and so on. So here is the workflow for monitoring and managing treatment plans of orders in between visits. And right away in this upper left-hand corner, you can see one of those patterns. I've highlighted these patterns in something that should be close to red in your displays. And what's happening here is that the nurse coordinator doesn't know exactly when the notes are going to be released that have the orders, the new orders in them. Her best cue is to go back and look at a hard copy of the clinic schedule that she marked up in order to call the patients and remind them. She keeps hold of that piece of paper for another couple of weeks until the doctor notes have been approved and released, and she sees them for all the names that were listed on that piece of paper as MS patients. And so you can imagine how often she might waste time checking to see, well, this patient has been seen 4 days ago, and pretty soon I should be seeing the doctor's notes. And finally, we'll call the doctor if she doesn't see them. Here's another place where the nurse has printed the doctor's notes and put them in a stack because she needs some convenient way to reorder the patients based on priority of changing situations. She's also recorded them in a spreadsheet that's used to track all of the orders. Here's where she reorders that stack, and then as the orders are completed, for example, a lab report, and she gets a copy of that test report back, then she'll update the Excel spreadsheet that she first entered it in. So you can see all of these things going on around here. Finally, when all of those orders have been resolved, she'll shred the hard copy of all of the notes that all of the hard copies that she's made. We have a way of recording the use of information in this tool. It's called Math, and it's the second reference in the notes that will be available to you. And what you see here is that we've opened up the properties sheet for this task, and we're recording that in order to start this task, she needs the patient's name and the doctor's order, and then she's going to turn around into the spreadsheet and enter the order and the patient's next appointment date. Okay? And in this way, we're actually able to accumulate an information dictionary. And this information dictionary associates with each task in the workflow which information is needed, and we just indicated that here with zeros and ones. So for example, you see a pretty similar pattern between 2 and 3. That might be heart rate and blood pressure. They tend to be used in the same place at the same time. Over here, this might be A1C, and that's just kind of loosely correlated. So this information dictionary allows us to look for patterns of use that correspond to these problems. And as I said, there's more detail of these tools that are really beyond the scope of this talk in reference number 2. What we're going to do now is show you a video of a new system that was created in order to assemble all the information that's needed in a way that's an appropriate match to the workflow of care. So if we'll begin that video now.
Patient-centered case management reorganizes the information needed for case management to support a cognitive strategy of management by exception. Management by exception is appropriate when there's a well-defined plan, and it reduces workload by identifying deviations from the plan, and that focuses attention on where they should be fixed. This user interface is designed with layers of information for layers of questions that correspond to the strategy. At the top level, you see there are a number of filters that can be applied: new orders, next visit, aging orders, and so on. So one of the questions that we'd like to ask is, in the first part of the cycle of case management, who has new orders in order to become aware of them so that they can be managed? And we have 2 patients who recently have new orders issued. Let's take a look at this one. Mr. Cruz has a lab and an image, and they were issued on these dates. They're expected to come in pretty soon. And so these look reasonable, and we're going to accept responsibility for managing those. And when we close them and go back to new orders, and you see they've dropped off the list that have been flagged with new orders. The next question at the top layer of information is which patients have an appointment that's coming up pretty soon. And so you can see that this has been sorted by their next clinic appointment. And right up at the top here, we have Mr. Bowden, who's got one coming up in a little while. And it looks like this red code means he's fallen behind in his orders. Let's take a look now and get into the middle layer of information and say which orders is it that are not progressing. So there's a lab, there's an image, and there's a neurology appointment. Okay, it looks like the neurology appointment has been scheduled, and it's going to take place in time for the next appointment. We don't want to keep getting flagged on that, so we're going to set the date for when it's scheduled. It's not going to happen as soon as we expected, but it should be something that we can live with. Okay, now we won't keep getting flagged that this is something that is we need to pay more attention to, because it has been set and there's not much more that we can do about it short of getting with the neuro people and trying to somehow getting them to accelerate the appointment, and that's probably not going to happen. On the other hand, these two need to be taken care of. So let's make a note to ourselves to call patient to ask them to get CBC and CXR done before next exam. Okay, and this will be a little reminder to ourselves. We'll ask them about 4 or 5 days before that next exam. Let's give them a call on the, let's see, the 20th. Well, we better call them on the 26th, the day before Thanksgiving. We could save that. Okay, let's close that up. And that illustrates how we can sort patients by who's got a near exam. The next top layer of information that we're interested in is, are there any patients who are not progressing regardless of when their next appointment date is? The next appointment date would give them more priority, but here's a patient, Kamala Heron, who seems to be falling behind in her orders. And of course, we'd like to identify that before it gets too late and be proactive. So based on these dates, it looks like she didn't go in for these tests, and the occupational therapy order was expected some time ago.
This was a model-based design analysis of how an expert user would be able to perform that user interface, and the estimated task times are in seconds. This is based on David Karas's model-based analysis of user interfaces. And on the right-hand side, you see the actual empirical values of a usability test that was conducted with in conformance with ISO 25062. And what you can see is that many of these tasks were very close to be able to be performed by the 7 nurse testers who'd only been given an 8-minute video beforehand in about the amount of time that would be expected if they were expert users. And that means it was very quick for them to learn. There's one outlier here, and that had to do with our ability to find new orders. We've gone in and fixed that in the design. Overall, this pattern gives us some evidence in favor of the idea that that user interface could be used for all the key use cases in the workflow of care. Now, that user interface took all of the information requirements that were distributed over those different overlapping information resources and organized them into a web-based application that could pull its data out of the daily warehouse dump for the EHR without disturbing the EHR's code, and simply repackage them into an organization that was effective based on the needs of the workflow. What you see here is a comparison of the new workflow on the right that's enabled by the patient-centered case management system and the old as-is. And you can see that all of the overhead tasks have been removed. The workflow is certainly a lot more streamlined. You can just see that visually. But the BPMN standard is well enough formed that it allows us to conduct a discrete event simulation. So we can actually simulate the difference between those two workflows. And again, the details of how to do that are given in the second reference that'll be included in the handouts that are available. And so, based on seeing about 80 patients a month, we can get a time savings of about more than 15%. That translates into a little bit more than an hour a day. We look at this in combination with the diagram of the workflow plus the usability test results, and we say that this gives us formative evidence in favor of how this new patient-centered case management application will affect the workflow in beneficial ways that are predictable. There's some additional expected benefits as well. Of course, much better situation awareness for the case manager, the patients, and even their families. They frequently call the case manager, and this gives her the visibility she needs to quickly find out what's going on for any particular patient. More timely completion of errors, of course, increased quality of information. Maybe most important of all here is that the clinicians can work at or near the top of their skill level. So instead of spending time on overhead tasks that really have no inherent meaning for healthcare, they're relieved of those clerical tasks, and they can spend more of their time doing what they were really trained to do and what they're distinctly qualified to do. Some conclusions from this case. One of the things that's most important is that before you begin to change a situation to make it better, you really need to understand what that situation is as a baseline before you devise some intervention. And workflow is a way that you can do that. Workflow really should be a part of IT design to avoid these common patterns of disruption that can actually have a graphical counterpart in a workflow model. Now, the BPMN standard offers a good way to do workflow modeling. It's been implemented in more than 35 commercially supported tools, not just the one that we have. And it makes a connection between health IT and the benefits to care. Now, what I've shown you is a model-based design, and you need to get access to clinical users in order to develop these models. You have to validate them, and that's a fair amount of work, especially when you compare it to something like agile programming. But what it gives you in return is an understanding of how workflow is going to be impacted. And it gives it to you in a way that can be validated in alpha testing before you go wider with deployment. It's a lot better for a highly skilled group of designers to figure out how workflow and health IT should fit together than it is to have thousands of users trying to figure that out on their own again and again. Great systems are not supposed to be easy to design. They're supposed to be easy to use. Thanks very much.
Thank you so much, Dr. Butler, for that great presentation. Our next speaker this afternoon is Dr. Amy Franklin, who is an assistant professor at the University of Texas Health Science Center at Houston. She is faculty member in the School of Biomedical Informatics and part of the National Center on Cognitive Informatics and Decision-Making. Her research includes studies on usability, decision-making, communication in teams, as well as medical errors and other adverse events. Dr. Franklin is currently on projects funded by AHRQ, NIH, and the Cancer Prevention Research Institute of Texas. And I'd like to now turn it over to Dr. Franklin.
Hi. I'd like to thank you all for the opportunity to share our efforts over the last couple of years working, as our title says, on opportunistic decision-making, information needs, and workflow in emergency care. Coming after Dr. Butler's excellent talk there, you'll see a number of emerging themes talking about how to give people the information they need to support the efforts that they are providing patient care during, and how that affects the kinds of decisions they might make. I do want to clarify that when we talk about opportunistic decision-making, we're talking about a specific class of decisions. We're really talking about how do you decide what to do next in the care of patients, rather than decisions that are embedded within the clinical decision support. So I have a few goals for today. These include tackling in turn, describing the relationship of cognitive burden and workflow in the emergency department. We want to talk about how to give people the information they need when they need it in a chaotic or potentially chaotic environment. Next, we'll cover our ideas about how we can improve situational awareness through dashboard displays and other kinds of visualizations, and how that will improve their decision-making ability. We'll cover a little bit about the potential for health IT to influence decision-making through our dashboards and other kinds of visualizations. And importantly, I wanted to walk you through some of the challenges that we faced in creating these real-world situations and solutions, and describe our ongoing and future efforts. So, the selection of the emergency department. There are a lot of unique features of emergency medicine that helped us select this as our domain for our research efforts. Emergency departments are complex, non-deterministic environments. And what we mean by that is you never really know who's coming through the door, what kind of conditions they're coming in, how stable they are. You don't know when patients are coming in. Are they coming in individually? Is there literally a busload of individuals needing care? And because you don't know who and when they're all arriving, you might not necessarily know what resources you have at any given moment, including all the other sick patients who might be there at that moment, your staffing levels, your beds, your supplies. There's a lot that you don't know in emergency medicine that creates a complex environment where decision-making may be challenged. So we're talking about here how to support physicians across, physicians, clinicians, nurses, many, many roles, in how to manage this environment and make decisions that allow them to consider the global needs of the entire department as well as the local needs of individual patients. Again, our focus is on opportunistic decision-making, which we view as a deviation from plans and protocols. This reflects not only the accommodation to this really complex environment, but it also increases the potential for risk and error. We'll talk about how we're trying to support different types of decision making. So to give you some idea what we mean by these task transition decisions, when a doctor or a nurse or a charge nurse is trying to manage her staff, they're moving between a lot of tasks because they often have any number of patients from 4 to 8 patients that are assigned to them. If they're attendings, they may have their patients they're caring for as well as all their patients of their trainees. As they move between patients, responding to an emergency that just walked through the door or caring for a patient over a number of hours, they have to decide at each transition, what should I do next? Should I go see the patient at the end of the hall? Should I go see the patient I'm standing next to? As we've done observations and other studies over the years, we have found that less than half of the decisions they're making are following a plan or a specific protocol. And the plans can be as basic as see a patient, document what you just found out in that visit. What we find is that instead, clinicians are being guided by having limited local information determine what they're going to do, rather than having a global perspective of where the entire department is and where their next task might be best served. What we find is that clinicians are being influenced by things like interruptions, or what we call breaks in task, where somebody comes up and says, we need you in this trauma room, or a patient is arriving in 5 minutes, prepare for that. Or opportunistic decisions, where instead of making a choice or the next task based on having full information of where their time might best be used, instead they're saying, I'm standing here and there's a patient right next to me, I'm just going to see this patient first. And so we have, over the course of a number of years, found that this opportunistic decision pattern and these breaks in task governing the majority of decisions holds true across different types of clinicians, attendings, residents, as well as nurses. We have, across over different environments, found that the balance of opportunistic decisions and interruptions may vary a little bit. So, for example, nurses do get interrupted a little bit more than doctors. And as emergency departments have changed their physical structures to have small spaces that have dedicated computer systems, so that's where they go in and do their EHR work, that actually has an influence on how they manage the overall department, because as they sit sequestered in those small spaces, they tend to interrupt each other a lot, and they tend not to be able to take as many opportunistic decisions because they are not physically moving through the space in the same way that they might previously. But we think that these opportunistic decisions and these breaks in tasks are actually being generated because of the complexity of the work. The work in the emergency department is highly interruptive, and it's interruptive because under those circumstances, there's very little opportunity to review documents that are fully noted for all the conditions or all the information you might need for a patient. In fact, some of our efforts found that up to 52% of the information in an ER is actually communicated verbally, because I don't know whether or not the lab is back on that patient, and I don't know whether or not that patient has had a procedure done yet for the next stage of care. So what we have is a lot of exchange between individuals where they're trying to gather situational awareness from one another, because it's not currently available to them in a ready-to-access form. We think some of the implications for these kinds of opportunistic decisions of treating the patient who's next to you or interrupting someone to achieve your goal is potentially the risk for adverse events. As we said, opportunistic decisions are actually a deviation from a plan or a protocol. So they may have unforeseen implications downstream, that patients may take longer to receive care, they may take longer to return to a task following an interruption. So we might also see increased length of stay over time across other patients, because this may be a suboptimal way to manage a department. Additionally, for patients, there may be decreased satisfaction because, again, in this non-deterministic environment, it's really hard to tell them when you're going to see the doctor next. And their situation awareness of what's going on is also poor. So we believe opportunistic decision-making is being triggered by these environmental factors, and that it does have an impact on patient care. Our hypothesis is that if we increase situational awareness, that is the ability for people to understand what's going on in the department, how many patients are there, what state they're in, what's going on with those patients, not only understand what's going on, but comprehend what that means for their practice and project forward to the future for the kinds of decisions they need to make, or project to the future for what will happen if nothing changes in the department. This will help them understand how to make appropriate choices in selecting what should I do right now, what should I do next. We think that this improved situational awareness through these dashboards and through this visualization will actually lead to increases in productivity, meaning they'll get more patients through. The patients will stay a shorter amount of time because each patient would be visited in turn when it was most appropriate and most actionable, that when you went into that patient's room to draw their blood or you went into their room to perform a procedure, that patient was in the appropriate state for your intervention at that time. So to support the decision-making through visualizations, we really have to understand the work of clinicians. And because we don't want to build a dashboard that only fits one facility, but really we want to build things that support all of emergency care, we've decided to represent the work of emergency departments using what we call a work domain ontology. And a work domain ontology is just really a machine manipulable way of saying all the stuff that goes into work. We want to talk about the goals that people have that they want to achieve in that work. We want to talk about all the information, as Dr. Butler talked about, as information as a requirement for completing a task. We want to talk about all the activities that they have to complete. We want to talk about the roles, who can do that task and who can't. And all the constraints in the system, meaning is there a particular order that things have to happen? Are there particular bodies that have to happen? Those kinds of things. And so we're using a work domain ontology as a way of representing that work. This is just a broad example to show that we have goals and objects and operations and constraints. And so, for example, in our hospital, we view that there are three main goals in emergency work. One goal is to care for patients. One goal is to manage the department in the hospital. Third goal, because we work in some academic sites, is actually to train clinicians. And so our work domain ontology breaks it out into these three main goals, of which there are, of course, sub-goals. Within each one of those goals, there are, again, the tasks and the objects that are required to complete that work and the constraints that make it hard. And the goals may be running contrary to one another, such that due to patient care and the need to treat that patient immediately, you can't train a resident on that particular task. Or constraints, such as I'll describe in the next slide, that say you have to do certain activities in a particular order, and that may be mandated by the management of the hospital or federal policy. So to give you a specific example of something that we're trying to understand as part of work and what's required to go into it, who can accomplish it, and how do we understand all the little pieces and how they interact? I'm going to give you the example of a medical screening exam. So a medical screening exam is basically the check when you come into an emergency department that you're actually really in an emergent situation, that you have an emergency medical condition that needs to be stabilized. Now, this isn't the same thing as getting a triage by a nurse where she's asking what your chief complaint is, she's checking your pain level, she's collecting vitals. The medical screening exam actually is required to determine whether or not the patient requires emergent care prior to other kinds of activities, such as collecting insurance information. You can't collect insurance information until you determine whether or not the patient is sick. And by sick, I mean an emergent medical condition, because insurance should not determine the ability of the patient, not determine the reception of services. So in our model of all the work that happens across emergency departments, we have this MSE built out where we understand that it requires certain pieces of information and it requires certain people who can conduct that work. So, for example, some of the hospitals have mid-level affiliate providers like nurse practitioners complete the medical screening exams, and other hospitals require that it's a physician itself. We build out the constraints of the system. So, for example, one of the hospitals that we work at has a different workflow depending on how many patients need a medical screening exam. So they have policies in place that say if a certain percentage of patients have gone more than, say, 4 hours in the waiting room without receiving a medical screening exam, they actually shut down their rapid treatment area, and all those clinicians go out and complete medical screening exams. So we build out across the work domain all of the different kinds of tasks and components of work that it takes to achieve the care of patients, the management of the department, and the training of clinicians. And we track who's necessary for each of those tasks, what roles are actually interacting when, so that as we start building visualizations to support them, we know who uses what information, where, and how. And we believe that human-centered visualizations that are systematically created using this kind of system can be used to improve situation awareness by giving the right information to the right person at the right time. So the goals of our visualizations are, through the presentation of information, support clinicians in their work by fitting it into their workflow. We want to present information appropriately, meaning that we decrease the cognitive burden that physicians and clinicians, nurses, medical directors are all under by removing the mental calculations that they may currently be doing in their head or on those little pieces of paper that they have to then track and apply as it regards to things like how overcrowded or saturated the department is. How many available beds are they, and are those the beds I need? What do I need to facilitate the movement of patients across different units in the hospital? We also believe that these kinds of visualizations that support situation awareness will lead to fewer interruptions because it will allow clinicians to seek information from another source other than other clinicians. And we have sub-projects looking at things like how often do you get interrupted in emergency medicine, not for something that relates to your work, but because you're a proxy for someone who might know something I might need. These boards would then provide that kind of information and reduce the need to interrupt others. And we believe that as we support the visualization of information in the ED, we're going to impact these patterns of decision-making or task transition decision-making and help clinicians seek and select the most appropriate next action based on the information available to them, rather than opportunistic factors like who they're standing next to. So in order to figure out what exactly the information needs are beyond what goes into the work, but what are the reported needs across different kinds of hospitals so that we can build out this model, we've actually done observations for about 800 hours of different types of clinical practices. We've conducted interviews and we've conducted surveys with clinicians. We engaged a number of different types of emergency departments, including a Trauma One medical center, a local county facility, and to a lesser degree, other smaller community-based practices, trying to understand the full range of what it means to practice emergency medicine. We've conducted ethnographic observations, that is, we go out and we actually shadow the clinicians. We've shadowed physicians, residents, mid-level providers, nurses, charge nurses, a wide number of different roles. We follow them around, physically observing what are their actions and who are they interacting with. We have audio recorders on them so that we can piece apart the difference between being interrupted by someone and talking to them because it was by chance and proximity you came into contact with them. We've conducted interviews with a variety of roles to find out what exactly they need or believe they need. We've conducted surveys, and of course, we have a wonderful collaborative team that's part of our AHRQ group, including physicians, nurse assistants, physician assistants, nurses, and others. We're also very lucky in that we are working now in conjunction with an ED collaborative for a hospital system, and we're working to deploy at 11 of their sites in conjunction with their dashboards projects. So, to get you started, I thought the best way to explain where we ended up with is actually to show you where we started from. So I'm going to show you a progression of our dashboards over time to help you see how both we as the designers and the people we were serving had to come together to understand what kind of information do you need to make actionable decisions on, and what kind of visualizations best support that kind of immediate understanding. So this is the very first starting point for the boards in our initial grant submission. When we got started, we thought we need 3 boards. We need a board that covers the ED as an enterprise, talking about the resources available in the facility, talking about the resources available at the hospital level. We also believed that we needed a physician-level board to help the physician select their next patient, how to manage across a smaller subgroup of patients, as well as a patient-provider board that would focus on the individual patient and perhaps help you select whether or not this was the appropriate time to see that patient. As you will see across the boards that we've developed out, we have not only kept some of those themes but expanded in many other directions. And what we're doing now is a phased rollout of different types of boards. So initially I'm going to show you the phase 1 rollout that included more of the ED resource level. Then we'll talk more about the provider and the orders and moving down to a more granular level. Now, as I mentioned before, one of the important things that we had to do over time is understand the difference between information you want to know and information you can do something with. And so we worked really hard with the clinicians to figure out what are the levers that they can pull to change the action or change the flow of what's going on in the department, and what information do they need to make those decisions. One of the things that we noted from going from the original sort of idea of here's where it is at this moment was an idea of you kind of need to know where you were coming from to some degree. So there was an issue of wanting a historical progression to know, has the department been swamped for the last 8 hours and we're now seeing a recovery period, or are we riding the crest of a wave of just a massive influx of patients and things are going to get worse before they get better? So you see here we're looking at trends. We've got incoming, current, and outgoing patients, and that's a little bit different of a view. This view is a view that we built specifically looking at our county facility because their challenge there, well, one of their challenges, is often having an immense waiting room population of 50 to 100 patients waiting to see a physician for any number of hours. As I mentioned, this group is particularly interested in the medical screening exam, and right now I'm circling this bottom component here. What's happening in this board is we were thinking, well, maybe we need to present things to people in phases of care so that you can understand the difference between a patient who's waiting to see a doctor, a patient who's in process, or one that's got a disposition so that you know how many of my patients are in what kind of state. We've got columns that indicate different kinds of units or different components of the units, and the coloration changes here are really indicating whether or not a given patient is above or below a threshold. So each one of those little bars is a patient, and each one of those patients is then showing their overall length of stay in the department. And so this was one of our passes at trying to understand what information do you really need? What information can you act on with the intent here that maybe you would grab a patient and say, hey, this patient has been boarding a very, very long time. They're a critical patient. There may be limited ICU space, but let me find out what's going on. Now, this is where we actually ended up. This is the current version of the census board. And the idea behind this board is, again, to give situation awareness. We want people to look at the board and understand what's going on right now, comprehend what the implications are for having the board in this current state, and be able to project forward to figure out what their next action should be. So if you can't see my mouse, let me know. I'm indicating here that across the top of the board, we have what we refer to our banner. And in our banner, we're indicating the number of patients who are here now, the patients who need that medical screening exam, the number of patients in a care area, and those patients with an admission decision who are currently boarding in the department, consuming resources, but waiting for a bed. Let me clarify that this board and all the boards I'm showing right now are supposed to be applicable across a wide range of roles. So we do allow for filtering to let you select different types of patients, but as part of our design, right now these boards may be used by multiple people for different purposes. So a nurse may look at these inpatient admissions and the open inpatient beds and say, who do I need to call to break this backlog? Whereas a physician may look at this open inpatient bed and try and decide what's the most appropriate placement for their patient depending on what's available. You'll also see changes across time. So while we originally thought length of stay was an important feature of the patient, it turns out that through a discussion of the use of this board with our clinical providers, we found that they really needed to know the care areas the patients were in and how sick they are based on their emergency severity index score. And so instead of showing the length of stay per patient and having each bar be a patient, we now have them in an aggregate form. Additionally, you'll see things like a little bit of historical information, and this is not set to a very long time period. But the idea here is, again, to let you know, are you riding the crest of a problem that is developing, or are you coming down off of a very busy time period and you might expect decompression in the department? This next visualization here is of throughput. So this is some of the components that we have seen in previous discussions about wanting to know where is a patient in care to know who should I go see, who's been languishing, who needs some attention. The idea here would be that at the top of the board, we have all of the patients in their entire length of stay across all processes. And the idea would be that those in gray are the ones that are within range for that particular threshold for care. Everybody who's in a color has been there too long in their process. And the idea would be you could pick off those who are outliers and go find out what do you need to do to move their progress along. Additionally, we have this broken down into very small subcomponents that cross different types of roles. So the time from when you arrive, get triaged, and get placed in a room may be a more nursing-related duty, whereas the time from when you're room to see the first provider covers both nurses and physicians. But the idea, again, here is to help clinicians understand where the entire department is and help them select individual patients who may be stuck in a particular process. Additionally, each of these thresholds, the time and where it flips between colors is actually set to given facilities and is guided by approaching thresholds as suggested by CMS. Now, one thing that we're trying to do, in addition to providing raw or low-level data, is actually give some composite scores. Now, the NEDOC score is the National Emergency Department Overcrowding Scale, and you'll see this small component here with a score and a color across the top of all of our boards. The idea here is that the NEDOC score reports the saturation roughly of your department and would help the department decide when to engage a surge plan, when to engage a plan for being overcrowded and overloaded. Now, the NEDOC score is something that's manually calculated in all of our facilities, or was manually calculated until we brought out the dashboards. The NEDOC score has a number of different components and includes everything from like the total number of patients in a department to the number of patients requiring one-to-one care. It also includes things like the longest admit boarding time, so how long has the longest patient been waiting for that bed, and the number of inpatient beds actually available. So the NEDOC score is up at the top of the screen and indicates not only what the category is, but that little asterisk star actually indicates how close you are to shifting over a boundary. The idea here would be to help the department not only take a look to see where specific bottlenecks might be, and some of that's evidenced here where it's showing the contributors to the NEDOC score, but also help them understand, are they approaching a time where they may have to engage a different plan? So these first three boards were all part of the initial rollout of displays. We recently released a physician workload board along with a lab and orders board, which I'll show at the end. Now, one of the things we have to do when we're creating these systems is figure out how we're going to evaluate them. Our plan has been collect the needs, iteratively design the boards, release, test, and then roll out the next phase. But for evaluation, we do have long-term goals of looking at things like the impact of these displays on the decision-making we talked about in terms of do interruptions go down, do opportunistic decisions change, and we do want to tie the use of the boards to things like efficiency measures in the department. How long have length of stays stayed or changed once they were enacted? But we also need something for immediate evaluation, and here we've turned to eye tracking. So this is a heat map generated by users evaluating a dashboard looking at a specific question. For example, we ask people to give us point readings saying how many patients are in the waiting room who are of an ESI of 3, but we've also asked for comparison data of which unit needs more resources at this moment, as well as things like, can you identify what the bottleneck is? Is the bottleneck the number of inpatient admissions? Is it the bottleneck the number of patients in the waiting room? Using eye tracking, we can not only look at where people ultimately spend the most time looking, but we can also look at the access of information. So what's the pattern by which they gathered all the pieces of information to determine where the bottleneck was? And we can look to see if there are things that are pulling their attention away from where we really want them to be focusing. This can be used to help us redesign and improve our boards themselves. Additionally, since the go live in June, we've been actively requesting feedback on the dashboards using standardized survey for usability. We've been conducting interviews and looking at log data to determine who's using the system and for what purposes. Importantly, we've been querying to find out, hey, you're not using the system, how come? What can we do to improve that? And ultimately, we'll track performance data over time. Now, as I mentioned, I did want to talk about some of the challenges in implementing this. And these are the things that any HIT system rolling out would experience. But some of the things we've been challenged with are things like the color scales. So as designers, we know that red and green do not belong on the same display for color blindness principles, and that some of the displays would be better shown through saturation rather than changes in color. But we have to work within the expectation of our end users, where the NEDOC scale is a national scale with those specific categories, and the colors attributed to that emergency severity index score at ESI value are things that they're used to from their EHR system. And so we've had to work with the give and take of what we want to build in and what our users expect. Similarly, for displays, there is a give and take between the cognitive principles of what we think would be most effective and the preferences of our end user and their ability to learn new displays. So rich displays that take time to learn have their place, but we have to figure out when and how to use those. Additionally, we have the challenges of trying to deal with what used to be a historical view of dashboards to now an active and real-time use. As you'd expect, we have some challenges with integrating the dashboards to people's workflow. Our system is not integrated with the EHR currently and it runs through a separate application, so there is a minor cost in switching back and forth. We're currently working with our groups to figure out how other displays might be more effective, having large-scale displays that are static on the walls, refreshing but not allowing them to move through tabs, or little pocket displays. So we're working on proximity-based displays and a number of ways of trying to make this fit more seamlessly to their workflow. Additionally, I just wanted to mention that we do have issues with trust and process. When you're replacing a manual activity with an automated calculation of a score, people really need to be able to go in and validate that the data is true and appropriate. And so working with our end users to understand that the calculation of our NEDOC score may be slightly different than how they do it manually, and helping them understand that our data is pulling from the same sources that they would pull from and coming up with the same calculations, particularly given that sometimes human action, such as closing out beds, is required to make the system accurate. We also have the expected challenges of training, policy, culture, and administrative changes. How are we going to keep this going over time? We're working through those as you would expect. In our ongoing efforts, we are deploying at a third site to study the effective decision-making and then the generation and use of these boards. We're phasing out new dashboards. The workload and the physician workload and the labs and orders rolled out a week ago, and we're looking to see how that's impacting performance, and we're evaluating our systems. Just to give you a quick look at this ED dashboard for workload, I just want to point out that this board allows clinicians to see their individual patients all at the same time to see, hey, where are my patients in terms of receiving all the results for their labs and imaging? If I come in and see this patient right now, everything's waiting for me, versus this patient isn't quite ready yet, and perhaps I should select a different patient to see. This would be different than the opportunistic decision of simply seeing the patient you're nearest to. Additionally, things like letting attendings or charge nurses look at the workload across different providers might help in their decision of who to help next, who to assign the next patient to, and who to provide additional resources to. We are, as I said, working on an orders dashboard. It's like the throughput dashboard, but it's helping to show where each given test is in terms of its processing by labs and radiology. This might help a clinician determine, should I use a CAT scan for this rule out or an ultrasound? And you might look and see, oh, the CT scanner is running 4 hours delayed. It might impact decision making that way. We additionally have a patient dashboard that's under construction, again, building from all of our previous concepts. And we have a throughput dashboard that we are trying to figure out the best way to train and teach different ways of visualizing information, like throughput metrics. So rather than presenting the number or proportion of patients who are above or below a threshold, borrowing from manufacturing, we might want to use something like a statistical process control chart to show whether or not there's really a phenomena underlying the variation you're seeing, a special cause, or whether or not this is all normal variation. And so across these displays, what I hope you've seen is the process that we're going through of trying to understand needs, understand a way to build a system that supports different types of users, building out displays that function both from a cognitive perspective in terms of reducing the amount of effort, number of mental calculations that people have to make, but also fit with simply what people are expecting. And how do we evaluate that this is actually going to make a difference in decision-making and ultimately patient care? I'd like to thank AHRQ for their support, as well as all of our wonderful local hospitals and the clinicians who have been involved in our study, and our amazing team presented here in alphabetical order. We are also very lucky to work in collaboration with the Memorial Hermann Hospital System, and I appreciate your time. Any questions outside of this can be directed to me at this address. Thank you very much.
Thank you very much, Dr. Franklin. We can now shift to the Q&A portion of the web conference session. Before we do, just a reminder on how to obtain CME CE credits. To do so, please visit the website on the screen. I'm going to shift to, again, show the screenshots so you can see where to type in questions for all panelists, and we'll then leave up the CME CE credit information for folks to look at while we cover questions and answers. Before we get started, I did want to remind folks that you should have received the presentation in advance of this web conference. If you didn't, they will get published on our website under the events section of healthit.ahrq.gov in a couple of weeks. So to get started, Dr. Butler, can you talk a little bit about how much time it takes to do workflow modeling and how you were able to engage busy clinicians to give their time for the modeling?
Workflow modeling, you have to have access to clinician users. The first project that we did that was located in Seattle, that was about 3 months from the beginning of the workflow modeling interviews until we had the as-is model pretty well in hand. That involved interviews with about 18 different clinicians. It involved observations. It involved follow-up questions, and then it involved prototype testing. The most difficult one that we've had is getting access to the clinicians in the pain clinic, and that was a little bit surprising. We thought it would be a lot more difficult for the emergency department, but the pain clinic, the clinicians were not always there, and so it was a little bit more difficult to schedule them. The emergency department at Baylor, we advertised the interview as a possible way that they could influence a new information system that might be coming their way. And that seemed to really ring a bell. We also offered $25 Amazon gift cards for people who had to come either before the regular shift or after their shift to compensate them for their time. And the interviews actually progressed pretty well, even though we're located in Seattle and we had to go down to Dallas. We have a very good team down in Dallas that helped us with the interviews as well. The events like the Ebola crisis there and so on, and then coming holidays, those are all things that you have to take into account. But I would say, generally speaking, you're looking at 3 to 4 months from the planning of the interviews, which is a very important step. You don't just go into the clinic and say, hey, can I talk to you? We actually build a matrix of roles and responsibilities, and then we sample within that matrix to try to find the most suitable person for the interview. We consult with management to make that decision. And then, of course, we have to do it through IRB interviewing, recruiting methods. And so all of that adds up to taking a little bit of extra time, but I would say that it's certainly something that's practical to do. You do have to make an effort to do it, but we were able to get access to the people that we needed, all of them, within a reasonably timely way.
Thank you very much, Dr. Butler. Dr. Franklin, can you speak a little bit about how you were able to engage clinicians and sites for your study and how that went?
Certainly. I will say that I feel quite spoiled in the number of clinicians who we have engaged in our work. Partially, our success has been due to an extensive relationship that pre-existed this project with the emergency department at one of our local facilities, but it has largely been through the shepherding of the project, through our collaborators, and through the hospital system itself that we've gained access to so many facilities. One of the things that has helped strengthen our project so much was the initial efforts of building out a model of emergency medicine in one type of hospital system, then moving to the others. But what really helped make the displays robust is when we went to all 11 of the facilities and found out the different pressures that they were under and the different constraints. And that was facilitated through the hospital system and through the ED collaborative, but also through the very active interest in all of our end users for having a tool that would support them in finding the information they need in less amount of time or effort. So I think our success has been due to support from the hospital system, support from our collaborators, and meeting a need, a recognized need by the clinical group. We've been able to engage both clinicians, nurses, medical directors, and other roles. And I think that it is through multiple points of contact that that's been achieved. And again, as Keith was pointing out, it does take time. Simply visiting all the sites and then figuring out the differences. Just as a specific example, when we were building out the amount of space we were dedicating to boarding patients, we were basing it off of our more local idea of maybe 8 to 10 patients, but it was only by visiting some facilities that had 20-plus patients boarding that we realized we really need to have flexible spaces that can accommodate these differences. And that's why having a generalized model and then accommodating those differences was important.
Thank you very much. Dr. Franklin, can you speak about what are some examples of ways in which the dashboards reduce cognitive burden?
Certainly. So some of the things that the clinicians are having to manage is what are the current states of all of my patients across different components. So while trackboards or the AHR system may provide some things like icons or quick counts for the patients, it's very difficult for them to see them in relation to one another. And so our workload dashboard that provides the same information across different patients, returning things like this information for any given patient is back or not, would help facilitate decisions that may be done only through mental calculation. The NEDOC score is one where it's actually a physical and a cognitive task where they have to search through the existing systems to pull specific pieces of information to then enter that into an Excel file while trying to track all of the other pieces of information that are coming in verbally. So how many beds are open or closed? Is that unit really functioning? We're pulling that all in and reducing the mental calculations that people have to create. Additionally, just trying to understand the status of multiple patients. Where do they stack relative to one another? What patient is the one in need of my attention next? And so we are trying to work with them to build in something akin to an ordering of their patients that might help suggest this is the best place your services might be used next. Recognition is also important for helping them perceive that there is a down CT scanner or that the labs are backed up. Typically, this takes several hours as they put in orders and have to track, hey, wait, that didn't come back yet. I wonder why. And then taking the extra steps to find that out. Having that information all available in a just-in-time display will reduce that kind of burden of memory demands, attention demands, and simply making comparisons across patients.
Thank you, Dr. Franklin. Dr. Butler, you talked about how you were able to eliminate some of the overhead tasks with the redesign. Can you talk a little bit about information needs that you uncovered that maybe were unexpected, and whether any of those cross different settings or clinical focus areas?
It follows my my concluding slide. Hello, we still got audio?
Yes.
Okay, good. If you could go to that, the last slide in my deck.
Okay.
Okay, go one more. And one more. Sorry for that. Yeah, I think there should be a class diagram in there. Can you go one more? No, they've removed it. Well, okay. I think the most surprising thing that we found, we actually created a class diagram of all of the information requirements. And the thing that was surprising to us was how that class diagram organization of all of the information that we recorded in the information dictionary formed into something that made an awful lot of sense, that there were layers to that class diagram. And right up at the top layer was the identity of the patient and the status of how they were doing against their treatment plan. And that actually suggested to us how the information architecture should be organized. The next layer down had to do with individual orders and the types of the orders and the expected durations of state changes of those orders. So, for example, a neurology exam involved first making an appointment with the patient. That involved contacting the patient. Then there was some wait until the patient actually attended the appointment. Then there was a write-up of the report and so on. So there was a workflow for each of those types of orders that unfolded over a different period of time. An occupational therapy appointment, what might happen quite a bit sooner. And so these different types of orders were supposed to unfold at different rates. And so it made sense to us that in this hierarchy that was exposed by the class diagram, that the identity of the patient and the status of how they were doing against all of their orders was sort of the first filter. The nurse coordinator is continually asking herself, which of my patients needs my attention next? And this became a very convenient way to answer that question. And then that allowed her to quickly dig in to more detail and say, well, why does this patient need my attention? Which of their orders is it that isn't progressing? And why is that the orders that are not progressing? Why aren't they happening? I think the sort of elegance of that organization and how easily it fit into a user interface and an information architecture, that was really surprising to us. Oh, okay, there's the state diagram. So if you could go one back, we'll see the class diagram. There it is. Okay. This is the class diagram that I've been referring to. And you can see there's the patient name and whether they're progressing right out at the top edge of that. And then the individual orders, more detail. And then the attributes of the orders are the deepest level of detail. Sorry about the confusion. I thought that was going to be right at our fingertips right away.
That's okay. I'm glad we got there eventually. Thank you very much, Dr. Butler. Dr. Franklin and also Dr. Butler, how would you extrapolate findings from your studies to other clinical domains?
I think, Keith, if you don't mind, I'll go first. I think from our efforts, a lot of the information may extrapolate in the exact form, but the methods themselves would. So understanding exactly how to identify what are the actionable decisions that are necessary versus information people would like to know, but information they can act on. Understanding that different roles will engage with the same piece of information differently. We are hoping that some of the visualizations themselves might become more useful. There are some initial efforts to include statistical process control charts in things like throughput metrics. Those may move from being part of an administrative set to actually being an on-the-floor set of how might this affect decision-making now to help people recognize outliers. I think that just the notion of having dashboards and understanding the time frame where the dashboards might be effective could generalize to other settings.
Thank you. Dr. Butler?
Yes, I believe that the design concept of the patient-centered case management tool should generalize pretty readily to other chronic disease care. Other physician specialists have looked at it and said oncology, nephrology, cardiology. Of course, it wouldn't be very difficult to change the rules and the types of orders that would be deeper in the class diagram. So I think anytime you've got a lot of patients with complicated cases, then something like the patient-centered case management concept could apply.
Okay, thank you very much to you both. And then last question. I know that you're both doing evaluation and testing as part of your projects, but can you speak a little bit about the transition from the previous or existing system to what you developed through your project and how that went for the users?
Well, again, for our system, there was nothing existing in terms of a full dashboard. The users had access to a smaller trackboard that was essentially an Excel file that allowed them to look at patients, but all of the understanding of how the patients stack up against one another or require care were based on rough sorts. They are not embedded within the EHR system. So it is not that we had to work with a competing workflow, but rather we are introducing a additional tool that is outside the application itself. And so our challenges have been with new implementation rather than supplanting something that existed. And so we are having to work with the end users to provide elbow support to make sure that they're able to access it. We're working to understand the challenges or barriers that are keeping them from using it. We're trying to understand ways to help it better fit with their existing processes, including helping them understand its utility so that the minor cost of logging into this additional application is seen to be outweighed by the benefits that are gained. And so ours is sort of a new rollout.
Thank you, Dr. Franklin. Dr. Butler, did you have anything to add?
Yes, the status of the patient-centered case management tool is that it's a fully functional web application. We don't yet have authorization to hook it up to the daily data dump in the VA, so that's still pending. The best evidence that we have about how it's going to impact the users has to do with some really enthusiastic statements that are made by the nurses who served as testers, saying, wow, this would really save us an awful lot of time, and this would free me from doing a lot of what they refer to as secretarial work. So that's the best evidence that we have so far. We're looking forward to getting permission to move into the alpha test.
Thank you. And we did have one additional question pop in, and Dr. Butler, I believe he sort of began to address that question, which is whether the tools that you've developed are standalone outside the EMR, and if so, whether they're homegrown tools or commercially available.
Okay, so there's two kinds of tools that I've talked about. One of them is the patient-centered case management system, and that's a standalone web application that would not require any changes to the code of the EHR. It would feed off some sort of report out of the EHR. The math tools, there is a diagramming tool that's based on the BPMN standard called MathFlow. There's a matching simulation engine called MathSim. And then there's an analysis tool that looks for clusters of attributes based on workflow patterns of use and suggests classes based on those clusters of attributes. Those tools are university-level research tools, and they're not commercially available. If you contact me, we would discuss giving you some kind of a license with some kind of support to make sure that the software holds up while you're using them. It's reached a stage where it's pretty stable now. There are other tools based on the BPMN standard that are commercially available. Visio is one of them. Visio has a shape library based on BPMN 2.0, but it doesn't have the information dictionary behind it.
Thank you again. And Dr. Franklin, can you speak a little bit about the visualizations that you've developed and their availability?
So our visualizations are pulling off of data from the emergency department data warehouse. So they are not directly accessing the EHR itself, but accessing the warehouse. So there is a small time delay there. But the visualizations themselves are actually in a commercial off-the-shelf product. It's in Tableau. And again, our collaboration with the hospital is what made this possible, as they are running an enterprise variant of Tableau. And then the visualizations are created within that system and then displayed within their access of the system there. So ours are commercial products.
Okay. Thank you. Well, I'd like to thank both presenters again very much. Thank you all for joining. And be sure to go to our website for the slides and the recording of the presentation. Have a great afternoon.
Thank you very much.